All right, it's 12:05. I'm going to be respectful of everyone's time. And Monday morning, Monday afternoon, Monday lunchtime. I know we all have just a little bit of break and took the time out to join the call. So first of all, I'd like to say good afternoon. I'm Valeria Levy. I'm the new interim executive director for North Carolina AIDS Action Network. And I'll take a minute to introduce our team that's on the call. Christina, if you would wave and say hello, as well as Matt, who is there somewhere, who's not going to wave because he is getting ready to go to West Virginia and joining us in the background. So I appreciate that. Thank you so much, Matt. You all probably know Christina, who is our Policy and Communications Director, as well as Matt, who is our new Associate Director. Now, you all have joined us today, and thank you. Let me admit some more person. Christina, could you help me in the background admit, or can you? Or no, I believe it has to be Catherine, who is my co-host. Catherine?
Yeah, I'm doing it. I'm on it. I'm on it.
Yeah, you add me as a co-host, I can be doing it throughout the presentation. That way, presenters aren't distracted with that.
Okay, fantastic. Well, let's do that. Are you at it now?
Not yet.
Okay, I'm going to work on that.
Okay.
Okay. All right, well, today we are going to highlight the current impact of monkeypox, which some of you are starting to see a new, I want to say acronym just because it's not monkey spelled out. You're looking at, most times people are referring to it as MPox. And so we're going to talk about that today in regards to North Carolina. Really going to make sure that you all know and can share the information as to how to access testing as well as vaccines. We're going to do a review that's going to be provided with a very clinical presentation of MPox, STDs, STIs, co-infection data, community collaborative opportunities, and things to increase awareness, testing, and access to vaccines, and make sure that we're achieving all the health priorities. So we've got our North Carolina DHHS team with us. If you all will wave, salute, whatever you prefer. I've got Dr. Zack Moore, who is the state epidemiologist and epidemiology section chief. And then my co-host is Catherine Guerrero, who is the vaccine program manager and health equity lead. She's on the call. We've also got Robin Deacle. Robin, am I pronouncing your last name right? I was right. I love it. See, I'm a Valeria, so I understand when it's not quite right. So Robin Deacle, who's the Senior Director of Office of Communications. And I believe, am I missing anyone, Catherine, that's going to be presenting today?
Nope, I think that's it. We have a few more folks. We have Esther and Erica who will be helping us answer questions and filling in some data, but I think you got the presenters.
Fantastic. Well, we're going to start this off with Dr. Moore and get the information shared, and that's on your screen. So Dr. Moore, it's on you.
Okay, great. Thank you.
Thank you.
Thank you all for being with us, and thanks, Catherine, for running the slides. So before we jump in, I just want to say first, it's good to see some familiar faces or names on here. Also, equally good to see some unfamiliar names and faces, because we want to make sure that we're broadening this conversation about our monkeypox response as much as possible, and bringing new people in. It's been a very challenging issue to deal with, as you all know, from a variety of perspectives, not least of which is the many issues with stigma around monkeypox, one of which is just the name, and hence, as Valeria said, some people are using other things. We haven't really landed on one, so you'll still see monkeypox in there, but there's lots of challenges related to the groups that are being disproportionately affected. in this outbreak. And of course, the first thing that we saw with as this outbreak got started was the predominance of gay, bisexual, and other men who have sex with men in the cases. And then people living with HIV, you will also see that's another issue that a group that's being disproportionately impacted, as well as, you know, and I'm giving you sort of a preview of what I'll talk about in a second, but particularly in North Carolina, we were one of the first to kind of raise the flag or concern about disproportionate impact in the Black and African American community. So there's sort of this, you know, the groups that are being most heavily impacted are groups that also face stigma in, you know, in other ways. And so there's been a lot of good discussion, you know, about the extent to which we do or don't talk about specifically men who have sex with men or people living with HIV, and as we talk about monkeypox and issues of, you know, is that worsening stigma or increasing stigma? Is it, you know, necessary to get the information out to the groups that are most impacted, et cetera? There's lots that we can talk about, and I hope we will if I stop talking at some point here. But just all that to say, it's really important for us throughout this that we're engaging with people in the community, and not just the community, but you know, different communities around the state that that may be especially impacted by this current outbreak. So thank you all for joining, particularly with our partners at NCAN, you know, with people living with HIV, particularly being such an important group in regards to this response. This is a great opportunity. So thank you. You will see there's a warning, or if you're not looking at slides, let me just tell you there's a warning. I do have a slide here with some images of monkeypox rash or monkeypox lesions in genital areas, which is included because that is a very common feature with the current outbreak. But I will flag when we get to that slide, just in case you all are watching. If you don't want to see that, or if you're watching or logged on with somebody else who might not want to see that, just want you to be aware. Okay, so I'm just going to cover some background here, and then I'll turn it over to Catherine to talk a little more about our vaccine and treatment response, and then over to Robin for some of our outreach and communications. But hopefully we'll leave a lot of time for questions. So next slide, please. Okay, so very important to start with, how does monkeypox spread? I think the first thing that well, maybe a couple things, not first anymore because I've been talking a while, but it's important to know that, you know, monkeypox is not new. We've known about monkeypox. The virus was discovered in 1959, the first human infections in the early 70s. So we've known about this for a long time. It's not COVID, but that doesn't mean we know everything there is to know. And, you know, when there is a disease that's primarily affecting people in sub-Saharan Africa, it does not tend to get this type of attention and resources as a disease that's affecting us here in the United States. So I just want to put that out there. Everything we're saying now is our current understanding, but we always need to have a little humility that we may learn more as we go. So what we do know is it's most often spread through close contact. And when I say close, I'm talking direct skin-to-skin contact with somebody who's got monkeypox, rash, sores, or scabs. This is the reason I gave that little note of caution at the beginning. There are some studies now where they're finding monkeypox in rectal swabs from people who don't have any apparent rash or illness. It's not clear what that means. If that means that people can transmit when they're not having symptoms, that doesn't necessarily follow just from finding it to whether it's possible that they can transmit in that way. But as of right now, it's contact with folks who actually have the monkeypox rash as a primary mode of transmission. Unfortunately, it can also spread through contact with objects that get the virus on them, particularly clothes and linens, things like that, not so much hard surfaces, although there's, you know, a lot of concerns about toilet seats, et cetera. It doesn't really survive long in that type of situation, but certainly there are risks with things that might get the virus on them and then be touched by someone else. And then respiratory droplets, again, is a great place to talk about monkeypox not being COVID. It can be spread through respiratory droplets. but it's much, much, much less infectious in that way than COVID. So you're certainly not, like COVID, you walk into a room with somebody with COVID, you may get it. Monkeypox really requires much more prolonged face-to-face contact. There's been very little transmission when people have, even sat next to somebody on a plane for a long time, et cetera. So it is possible, but much less infectious and closer contact needed. And then pregnant individuals can also pass the virus through the placenta to the fetus. So that's another important thing to keep in mind, particularly as we start to see cases among females. Okay, and then in terms of how long it's infectious, again, what we have right now, based on decades of experience in a totally different context, is that people are infectious until all the scabs have fallen off and there's a fresh layer of skin underneath. So that's some high-level background there. Next slide, please. Okay, and this is where I'm gonna, can't see them right now, but this is where the slide where there's gonna be some graphic images. So that's just another heads up in case people are not wanting to see that. But starting with the text over on the right, it doesn't start off with a rash, and I think that's like a lot of things that we've gotten used to. People generally start with flu-like symptoms and lymphadenopathy. Apologies for the some of the medical jargon, but that's swollen lymph nodes, which can be, under your arm, in the groin, wherever. Those are often the first thing that happen with monkeypox. And then the rash, if somebody has that part, which we call a prodrome, the rash generally appears within 5 days afterwards. And the rash can sort of start in a lot of places at once, all over, or it can be localized. And what we've seen a lot with the current outbreak, where a lot of the transmission is happening during sex, is that the lesions are often localized to the genital or the rectal area, or sometimes to the mouth, based on sexual exposure, and not sort of all over. And a lot of times those localized lesions don't have a prodrome, don't have that flu-like symptoms beforehand, but it's a bit of a mix, and we definitely are seeing people with more widespread monkeypox lesions. The picture you can see right here is the progression. So it doesn't sort of start off with those sort of pus-filled things that you see in some of our communication materials. It starts off with early vesicle, which is like a blister, or even just sort of a red spot that then turns into a blister. And then you can kind of see the progression. I'm not going to walk you through it, but these kind of firm pus-filled lesions that you can see and see there. And then those often do open up and ulcerate, and then eventually the scab forms and then separates. And then, as I mentioned, in the current outbreak, different than what we're accustomed to with monkeypox prior to 2022, it's often more localized lesions, often without a prodrome or a flu-like illness beforehand. And these are just another couple lesions you can see here in other parts of the body. And then the last one more click, Catherine. These are the pictures I was mentioning with some of the areas where we're seeing lesions now, around the rectum or on the penis, or in the the genital regions, the vulva, etc. We've also had reports of lesions in the mouth, or even in the throat, or some of the locations. Again, not exclusively, but where we've seen a lot of people having issues. And that's obviously a problem in a number of respects. One, pain control is a huge issue, particularly if you have involvement of a sensitive part of the body. But then another is scarring. So people can get issues with scarring if you have lesions in some of these locations that can be really problematic. So it's great that we're not seeing a lot of death with monkeypox, but that certainly doesn't mean it's not a serious, very serious illness and serious public health issue for us to be addressing. Next slide. Oh, go back one, sorry. And that was it for the pictures, if you were concerned about that. Okay, so this is just some of the other symptoms that we see. This is data from national data from the CDC, just to kind of tell you, which I circled in red, the ones that are most common at the top: rash, fever, swollen lymph nodes. Pruritus means itching. And then down in the middle, headache and malaise, which means just not feeling well, sort of tired and run down. And then at the bottom, myalgia means achiness. So achiness and chills. These are some of the more common things. And then some of the others really have more to do with where your particular lesions are in terms of what kind of symptoms people experience. Next slide, please. Okay, so this is just a little quick overview of where we are in this outbreak that was first identified. Well, I won't get into it too much, but it appears likely that this current outbreak kind of had started off in Nigeria, which is not a country that normally had seen monkeypox in the past. And then, the exact sequence of events is unknown, but the first detection was in the United Kingdom. Gosh, was that March? Could it have been March? Someone can correct me if that's wrong. I think it was March. And then really quickly after that was detected kind of around the world. People had not been thinking monkeypox appropriately, but once they started tuning into that, it was pretty quickly found all around the globe. So this case count from last week, close to 65,000 cases in countries that did not typically have monkeypox circulating. And in the United States, we're up around 25,000. And I'll show you our North Carolina data, but you can see about 4 out of 5 of those are known to be in men who've reported recently having sex with other men. And you can see some of the demographic breakdown. I'm not going to go into that, so I'll talk about North Carolina more specifically. Next slide, please. Okay, so this is just one more. This came out from the CDC, and I'll show you our data in a second, but just to say we're not alone in finding that often people who are being diagnosed with monkeypox are also either people living with HIV or people with a recent diagnosis of a sexually transmitted infection. So nationally, at the time this was published, 38% of the cases were in people living with HIV, 41% had a recent sexually transmitted infection diagnosed, and then it was about 2/3 of people if you add it all up together. So that's important information, obviously, for a couple reasons, in terms of prioritizing the people who are living with HIV or have recently been diagnosed with sexually transmitted infections, for vaccine and for awareness, et cetera. But then also sort of recognizing the importance of sexual health and safer sex messages in this response. So I think that's a really important, and again, another tricky thing, given a lot of people have sensitivities about referring to monkeypox as sexually transmitted infection, which I understand, but we've tried to thread that needle, and Robin will show you some of our safer sex messaging that we think is really important in this response. Next slide, please. Okay, so here's a little data from our state particularly. Sorry that it's a little cut off at the top, at least in my view. But we have even a higher proportion than the national data of people, monkeypox cases that are in people living with HIV. So it's more than half of our cases are in people living with HIV. And then the blue bar below that is people who've been diagnosed with any sexually transmitted infection, either within 3 months before or right around the same time they were diagnosed with monkeypox. You can see that's about 40% who fit in that. And you can see syphilis among those sexually transmitted infections that are diagnosed either before or right around monkeypox. Syphilis is the most common diagnosis in North Carolina. Next slide, please. Okay, a little more data, and sorry, this is a lot of numbers and graphs. The blue bars on the right just show the diagnosis over time based on when people had their symptom onset. We do seem to be seeing sort of a leveling off in the number of new cases. This might look like a decline, but that's just because we're still adding new cases, but it does seem to be leveling off a bit. If you could click once more, Catherine. This is my fanciest I get with animation. Just to point out, we are still seeing the vast majority of cases are in people who identify as male, 97%. And then click one more time. Yeah, thank you. Again, this disproportionality that has really persisted, unfortunately, since our very first few cases. Currently, about 70% of our of our cases have been in Black or African American individuals. So, big challenge in terms of trying to figure out how to address that disparity and how to work with people, particularly the Black and African American LGBTQ community, to to make sure that we're engaging in the right ways and helping prevent infections and transmission in that group where we're seeing so much. Won't go into the rest of it, but that bottom row, you can see people living with HIV, as I already mentioned, 53% as of last week. Next slide, please. This is just the number of cases by county. Mecklenburg was certainly early out of the gate, and we did see a lot of our cases in Mecklenburg. We continue to see new cases there, but it's definitely spread out. So for recent weeks, it's been less than half of our cases coming out of Mecklenburg. So still very, and Mecklenburg has done great work. Got to give a shout out to all of our local health departments, but particularly Mecklenburg, since they, had so much disease diagnosed there early. They've been very proactive in engaging with communities there. So, but really seeing it all across the state now. Next slide. Okay, I'm going to get into our response. This is just kind of a super high level overview of when we say monkeypox response, what are we even doing about monkeypox? So there's several things, and one of them is raising public awareness, and you'll hear more about that at the end. There's another part that isn't even on this slide, but is sort of our core public health that our local health departments are following up on each person who's been diagnosed with monkeypox, trying to identify contacts we can prevent or lessen the severity of disease if those contacts can get vaccine within a 2-week time frame after their exposure. So that's a lot of work that happens behind the scenes from our local health department colleagues. Testing early on, there were big issues with people getting turned away when they went for testing, doctors not knowing how to do testing. I'll talk about that more in a minute. Treatment. There aren't any actual, you'll hear more about this too. There aren't any actual FDA approved treatments, but there are treatments that were developed for smallpox that are available under an investigational use protocol and do appear to be having good impact. We're still learning more about that. So we've been working on that. Treatments and vaccinations both currently are only available through the government. So we've been with our local health department colleagues and lots of others working to make those accessible. And then vaccines, just mentioned, can prevent or reduce the severity if it's given within a tight time frame. And I think I will not say more about that because Catherine's got a lot more to say there, but this is just super high level. Next slide, please. And so I do see there's questions popping up in the chat, but I can't multitask. So I'm just going to power through and then we'll get to those. Testing. So I just wanted to say again, testing is widely available now. That doesn't mean that anywhere you go, you might not get turned away. We're really a big part of our effort is making sure that the doctors and the healthcare providers know how to test for monkeypox. They all really should be able to do it. And there's many laboratories now. Our state lab had been able to test for this going back decades, and they were the only game in town when this started, but now that's not the case. Lots of other labs that can do it. And so really it's about awareness and making sure that doctors and other healthcare providers know that they can do this, know how to do it, and feel comfortable with it. Next slide. Okay, at this point, I'm turning it over to Catherine.
That's me. Thank you, Dr. Moore. Hi, everyone. I'm Catherine. Happy to be here. I work with the immunization branch at DHHS at NCDHHS, and I'm the equity lead for COVID, monkeypox, and vaccines across the board, immunizations across the board. I'll talk a little bit about the Jynneos vaccine, which is the vaccine that's available for us right now for monkeypox. The vaccine is available under emergency use authorization for monkeypox. And what we know is that it can prevent or reduce the severity of symptoms if we can administer it within 14 days of exposure. It is possible right now, the majority of administrations happen as post-exposure prophylaxis, but it can be given as PrEP or pre-exposure for folks who are at higher risk. Right now, the vaccine is required to be administered intradermally, and that's about supply, right? Because we use less vaccine when we give an intradermal shot. Except for people who are under 18 or people who have a history of keloid scarring, and then the vaccine is administered subcutaneously. Sorry, I can't advance my slides and talk about them at the same time. Right now, like I say, is because the vaccine is being shipped directly from the Strategic National Stockpile, we don't have as much vaccine as we do some of the other vaccines available to us, including the COVID vaccine. So we have eligibility criteria, trying to focus on folks who are at the highest risk based on what we know about monkeypox. So anyone who's had close contact in the past 2 weeks with someone who's been diagnosed, gay, bisexual, or other men who have sex with men, or transgendered individuals who are sexually active, people who have had sexual contact with gay, bisexual, or other men who have sex with men in the past 90 days, people living with HIV or people taking PrEP who have been diagnosed with syphilis in the past 90 days, and then certain healthcare workers, mostly folks working in laboratory with monkeypox, are all eligible for vaccine. But I will say that those eligibility criteria, these decisions are made locally by health departments who are administering vaccine and with CBOs that are helping people navigate vaccine access. But these are the guiding criteria for getting a vaccine. So as we work towards increasing access and kind of making sure that we have vaccine where we need it across the state, when we need it, we pay close attention to race and ethnicity based on the disparity that Dr. Moore talked about earlier here. We see about 70% of the cases of monkeypox in North Carolina in Black or African-American individuals, but much lower proportionate vaccine uptake. So only just under 30% of vaccine actually being administered in these communities. Certainly we're maybe ahead of the game relative to the national numbers, but we have a lot of work to do here. So we spend a lot of our time working directly with local health departments and directly with community organizations to address access issues to healthcare in general, look at transportation issues that may be hindering folks from getting vaccine if they want one. Thinking about cost, and not just the cost of the vaccine. At this point, monkeypox vaccine is still free, but there are sort of ancillary costs, if you will. If you have to take time off work, if you have to travel far away, you're trying to think about the full range of costs that might be getting in the way of getting vaccine for folks who are at higher risk. And then stigma and anonymity. We worked pretty closely with folks on the ground to try to understand both where are the best places to offer vaccine, who are the trusted partners, trusted messengers, and then when we offer vaccine in communities, what's the best way to do that, to respect privacy and to give people the ability to self-attest to eligibility without any invasive follow-up questions, and be able to access vaccine pretty easily. And then a lot of communication out into the public, right? Trying to both give and receive information in ways that allow us all to work together better to get vaccine where we need it, when we need it. So in terms of vaccine administration, these charts mirror a little bit the charts that Dr. Moore just showed you. So you can see that the majority of vaccine has gone to men or male identified people. And then you can see we have a racial breakdown where about 30% has gone to Black or African-American populations, where we've seen the highest number of cases. And then 87% of the vaccine in non-Latino communities, and then most of the vaccine in 30 to 49-year-olds. And then you can see across the state, Jynneos is a 2-dose vaccine protocol. And you can see as we go forward, we have about just over half of the vaccines that we've administered to date have gone to be the first dose. And then we're starting to get into, just based on the timing of where we are, offering more and more second doses. Getting both doses is really important to reaching maximum immunity with the vaccine. So as you're working with community members, as you're working with folks who might need or be interested in a monkeypox vaccine, facilitating access to both doses is a pretty high priority for us. And then this is just a map of vaccine administrations across the state. You can see it maps pretty closely to the map of cases that, that Dr. Moore showed you. But we do know that people are traveling to get vaccine. We're trying to help with that. We're trying to facilitate access to both first and second doses by looking at both ways to support transportation, as well as ways to make sure that we're getting vaccine closer to where people live, right? So as more vaccine is available, as we're able to move it around the state more easily than we were earlier in the summer, we're getting better at this part in terms of where we're able and how quickly we're able to administer vaccine when folks need it. So I think that's it for me, just a quick summary of where we are across vaccine. Dr. Moore talked a little bit about treatment that's available that we do have a treatment called TPox that is available through the strategic stockpile, is available at no cost to patients. And we are working closely with local health departments and other providers to make sure that people understand the treatment, understand how to administer it. And again, to make sure that we can get it where it needs to be as quickly as possible, so that when people need it, it's available in time. Anything, Erica or Dr. Moore, you want to add about treatment? All right, then I'm going to turn it over to Robin to talk a little bit about messaging and outreach that's happening through our comms folks.
Can I ask a question real quick?
Sure.
Would you all, if people have questions about treatment, would you want to go ahead and take those questions now before going to communication outreach, or just wait?
Why don't we wait till the end, make sure Robin can get through these slides. She's got some great pictures to show you, and then we'll wait to the end and we can circle back to all the questions.
Okay, sounds great. Thank you.
Thank you all.
Well, fantastic. Thank you. As you all have heard, we have an explicit challenge in communications. Number one, there's a specific profile of people who are getting monkeypox in this outbreak. Yet anyone can get monkeypox, and we don't want our communications to stigmatize anybody. We don't want to make it harder to get treatment than it would, or tested than it would have been without our communication. So we have distilled down to a learn, look, and locate message for our overall communications. Learn the facts, which is that anyone can get monkeypox. And right now, some people are getting it more frequently than others. Number two, look for a rash. I have some nice pictures in this card that you can see, some that Dr. Moore has shown you, but to recognize that and know to go get tested. And so then locate your testing, locate vaccines for yourself and your community. If you do think you're at risk, we want you to go ahead and get that vaccine. We have put a QR code on here because our eligibility criteria has updated, our vaccine locations have updated, and some other details update as we go through time. So this lets you get the most up-to-date information. We took the learn, look, locate and put it onto what we called a pocket card. This is a kind of an election postcard sized document that you probably fits in your suit jacket pocket if you wear those anymore. But we have printed those to share with some of the community-based organizations. And we have another set being printed, actually 23,000 more we're working to get printed in English and in Spanish. And if you'll go to the next slide, Catherine, the flip side of this card actually has a kind of a risk matrix on it, which is a red level risk, a yellow level risk, and a green unlikely exposure level risk to help people understand, hey, how concerned should I really be? So those are the kind of two pieces that we wanted to get out there. We're starting to be more consistent, especially in our social media messaging, and helping to get people aware that there is vaccine if they meet some of these risk criteria. Catherine shared some a few minutes ago, and those have been opened up over time to allow more people to become eligible for vaccines. And we want them to be aware that vaccines are available. There's been a link at the bottom of both of these slides, and it will continue through the next two slides to this social media toolkit, communications toolkit. Actually, there are one-page flyers in there. This pocket card is in there, and we also have some social media graphics that I'm going to show you on the next screen. Catherine, if you can go to the next slide. These are graphics that we worked on with our health equity team. And the importance of that is the health equity team is a lot more out in the community. Catherine and her team are out in the community. I'm not out in the community as much, getting input from you all and hearing what it is that works. What's going to make me pay attention? What's not going to make me feel stigmatized? What's going to make me take that big step and go to a clinic and get tested if I have a rash that I'm worried about, or if I'm afraid I've been exposed. So we have a kind of a love yourself, take care of yourself message. And then this last one that's on this slide here is a safer sex messaging. Because while, I'm sorry, I'll let Dr. Moore correct me, monkeypox is not a sexually transmitted infection. It is something that is often transmitted sexually, especially in this particular outbreak. And we have found, or emerging science is showing that condoms and other safe sex practices can help lower your risk of getting monkeypox, just like sexually transmitted infections. I see Dr. Moore nodding. I'm going to go to the next slide, please, Catherine. The last thing that we have run is, and you'll see these animated GIFs start to rotate for you, is an ad campaign. And we targeted both dating apps and social media, as well as sites that are visited by people who fit the demographic of men who have sex with men, and like a shopping site, a celebrity site. If you follow their social media of gay or bisexual individuals, transgender individuals, you might see some of these ads. That one farthest on the left, worried about a rash that looks like monkeypox, was our most successful. But these other two were not really that far behind overall on our websites and social media. So just letting people know that everybody can get monkeypox, and that vaccines are available. They're free, they're confidential. Anonymity, you saw, was one of the big concerns of people seeking out treatment. So just trying to continue to get that message out there, help increase people's awareness, and just doing the best we can to deal with the bad situation. Sometimes I feel like that's what public health is all about. And then Catherine, my last slide is about what our current messages are. So they should see this reflected in those cards. That number one, monkeypox spreads through close skin-to-skin contact. I'll go back to Dr. Moore's first slide, and that anyone can get monkeypox. The caveat here being our data now shows that nearly all cases are in men who have sex with men. And while nearly 70% of the cases are in Black men, Black North Carolinians, we've actually upped this percentage. We're getting close to about 30% of the vaccinations. That's not where we want that to end. We need to really increase that percentage, and something that we continue to try to work with community organizations. It's a step at a time, and it is a slow process. But we have really seen that vaccine percentage creep up in the last few months as a result of some of that work. We'd love for it to be faster, but it is definitely challenging. And then I repeated here the learn, look, locate in plain text, so you all can have them. And those are the communications points that I wanted to hit today. Oh, our challenges. I was going to mention our challenges. Thank you, Catherine. The challenge really is that same data, it's necessary for people to know. If you are more at risk because you have HIV, that's probably critical for you to know to take care of your health. And at the same time, are we turning this into a gay disease? We've heard that both sides of this a lot, and it's something that is we're very aware of as we put some of these ads together. Of course, we have modified our ads over time as we have gotten input from the community. So very open to hearing more input if you all have some of that today. And then the last thing is we're coming off COVID response, which several people mentioned. Our resources are much more limited for monkeypox response than they are for COVID. So that can be a challenge as well. As I said, the equity outreach is very, a little step here, a little step there. And it takes more resources to make a lot of little steps than perhaps one big step, having one solution that hits a lot of people. So we're working through that and trying to make sure we do bring the resources to bear on this outbreak. I really will stop now and pass it back over. Thank you, Catherine.
Thank you so much, Robin. And thank you to the North Carolina DHHS team for putting this together for us and bringing the attention here to North Carolina so we all kind of know where we are. We had a couple of questions that came in to the chat. I'll take the first one. Mark Ambrose said he's wondering if folks living with HIV or contracting STIs are actually more likely to be getting MPox, or whether they're just more likely to be diagnosed because their HIV or STIs bring them in to see a doctor.
Hey, I can take that and then other folks can jump in. But yeah, it's a great question, and it speaks more broadly to like kind of a seek and you shall find thing. If we sort of, this first came to attention largely through, engagement of gay, bisexual, and other men who have sex with men sort of, coming forward, and clearly there is a disproportionate impact in that community, but there's also always the concern that when you focus on transmission in one community or in Black men who have sex with men or in people living with HIV, then that group, it's more likely to then be found in that group. So it does raise the question of who are we missing? Are people who are living with HIV more likely to be tested? Are doctors more likely to do testing in somebody that they know has had a recent sexually transmitted infection? Those are certainly possible things that could be happening. I don't think that really accounts for the entire disproportionality that we see in our data, but it does, it's a constant challenge. We've had cases diagnosed in children. We've had cases diagnosed in people who identify as female and have no contact with men who have sex with men. So we don't want people to not seek testing just because they don't fit a specific demographic. And that's why we always lead with anyone can get monkeypox. By the same token, we do feel it's important to share what we have in terms of where we're seeing the most cases diagnosed, but that can be a bit of a self-perpetuating thing. So it's definitely a good question, something that we're always alert to.
Thank you, Dr. Moore. Did anyone else want to add to that? Fantastic. Dr. Bass had a question as well. Dr. Bass, if you want to unmute yourself, you could ask your question.
Sure. Thank you, Valeria. I was curious because I've heard that, working with some other states that they're attempting to try to find temporary provisions to allow vaccinations to occur so that young people wouldn't have to have parental consent, but I wasn't clear or sure about North Carolina. So in North Carolina, what is the age requirement for the vaccination, and do minors have to have consent right now?
Catherine, I'm happy to take that unless you'd rather.
No, go ahead, Dr. Moore. Like to chime in.
Okay, and then I may be wrong, so then you can. But unfortunately, Dr. Bass, at this point, unless something's changed that I'm not aware of, parental consent, the vaccine is available to children, basically, but only it's approved for people 18 and up by the FDA. It's available for younger people under what's called an emergency use authorization from the FDA. And in North Carolina, vaccines that are available under an emergency use authorization do require parental consent. So I know that is a barrier, certainly, for some young people who may be at higher risk, but not feel comfortable getting, sharing that with their parents or getting parental consent for that. But at this point, that is remains a barrier here. I don't know if Catherine or anybody else has any better news to add on that.
No better news. I would just add, things got a little more challenging during COVID, right? Because some of the changes that came out of the legislature during COVID around who can consent and those kinds of things. I guess maybe the good news is that we continually looking at those criteria. Robin talked about the fact that we had expanded them in the last few weeks. Our hope as more vaccine becomes available and we're able to move vaccine better is to continue to expand those criteria so that there may be more room to have access to a monkeypox vaccine with less narrow criteria, right? And so being able to think about that and as a potential contributor to maybe some privacy for young people, but it's a really challenging environment for that right now.
I just wanted to throw it over to Matt or Christina and see if either of them had any policy information you wanted to share on that. I know this is still really new.
I know that we've had issues around not prior authorization, but like having parents get permission around like I think like birth control, PrEP, PEP, like we've seen this, and with the COVID vaccines as well, I think that was a conversation as well. So yeah, I mean, I think that there's absolutely room for policy fixes to be available for this. I know that, you know, like in the case of an abortion specifically, there's the judicial bypass route where folks can get out of having to get parental consent. I think having something something comparable, I don't want it to be necessarily a whole judicial process, but if there could be an easier process to where folks could have that option, because, you know, especially with MPox, you know, I can see that, you know, with a lot of the framing being very sexual, that in itself will scare parents from even being like, oh no, you don't need that. And, you know, even being able to have a more nuanced conversation around orientation, like some folks are not ready for that. And I don't think that, you know, an individual's health should be, you know, harmed in that way. So I think being able to think through what would be a sufficient policy to address that, and like knowing like that could get through like the General Assembly, I think that could be a good place for us to prioritize, because it keeps coming up, this issue.
Yeah, thank you, Christina. Go ahead.
Hypothetically, if a child is a sex worker, and they're estranged from their families, how could they if they're under the age of 18, how can they get the monkeypox vaccine?
Thank you, Rita. Catherine? Did you hear the question? I can repeat
I think I heard the question. The question was if someone is under 18, estranged from their parents, and a sex worker, how can they get the vaccine? So you know, I don't know the answer to that question off the top of my head. I will follow up and circle back. One thing I will say though is that, you know, a lot of these decisions are being made at the local level by health departments, with support from community-based organizations that are putting on events, right? And so we're taking a lot of guidance from advocates who are saying, look, we know these folks are eligible for the vaccine, we know there's people at risk, and trying to get as many people vaccinated as possible. Our goal is not to exclude people from vaccine, right? But you know, there's a challenge with some of the legal liability, right? And some of the who has where health departments feel, or where the vaccine administrator feels like they stand in regard to that. And that's where that decision gets a little difficult. I don't know that there are specific ways around that without formal emancipation, but I'll double check and see if there are other strategies that people are using.
Yeah, I think I don't have an answer either, but I think, as you mentioned, Catherine, I think it's part of the problem with monkeypox vaccine is this authorization problem. And I believe it was COVID that led to passage of legislation that anything that was available under an emergency use authorization required parental consent. This was part of the, you know, concerns from certain quarters about COVID vaccines. And so that is what's got us in a little bit of a bind, where we do have more flexibility about with approved vaccines for people to receive those. We've got this added barrier here when it comes to MPox, but throwing that out.
Thanks, Dr. Moore. Does anyone else have any questions? If you do, just raise your hand or unmute yourself.
Well, I was thinking because being that MPX is not a sexually transmitted disease, wouldn't it qualify under something else other than to have parental consent?
I think the challenge is not the STI or not STI. The challenge is the emergency use authorization, right? And so this was a policy change that I think, like Dr. Moore said, was in direct response to COVID vaccine in some ways. And so it's a little geeky, but the challenge with monkeypox vaccine, right, is that it was never intended to be used like this, right? It's a vaccine for smallpox that comes from the Strategic National Stockpile. That was intended to be a response to bioterrorism. I think Dr. Moore, correct me if I'm wrong here, but so we probably won't have mass-produced monkeypox vaccine, at least not relatively soon, right? In terms of, which doesn't mean we won't have more vaccine or enough vaccine, but I think the challenge is just sort of getting out from under that emergency use authorization, and what happens next around kind of the vaccine itself, the amount of vaccine. So it's on the other side, not necessarily the STI side of this. I don't know if that was helpful or not, but Dr. Moore, I'll let you fill in.
No, I think that is not the only issue, but from a vaccines under 18 with this condition, that definitely is the major challenge. I see
Thank
Evelyn's
you.
got
I
a
see
hand up.
Evelyn's got her
Evelyn
hand.
Taut is our
Yeah, hey everybody, and welcome to
Thanks,
the
Evelyn.
I don't know if y'all can hear me, but welcome to the call. Valeria, I was having a Monday myself. I can't get my video to come on. And I do have my lipstick on just for this meeting, so you guys are gonna miss it. But I do want to just say that we're bringing up an important policy point here that we do hope that North Carolina AIDS Action, will continue to look into and advise us and work with community. Because going back to what Dr. Moore said, the legislature really, did get into how vaccine should be delivered or not at that level of that he described. And so it does affect, regardless again of it's a sexually transmittable infection for sure, monkeypox. Aside from that, I like the way Catherine said that we need to be aware of in the going forward. I'd like to believe that both the COVID pandemic and monkeypox are it, but unfortunately that's not likely. So we're going to have yet another issue that, and the great news is the science has come along so that we can have access to vaccines and treatment, but we are going to need that flexibility, which is not, which includes being able to take care of anybody who's at risk. And we don't have that now. So I would like us, Christina, to get more educated about what it wasn't just a policy change, it was some legislative changes that we have to live with. That's different. Policy, you can work with, good people willing to make that next change. Legislation means law. So let's get educated and then see what we can do together, because this is going to come up again and again.
Thank you, Evelyn. And that's so
Thank
true.
you.
And I would have to remind everyone that we have an election coming up November 8th, and make sure that you are voting early and planning to exercise your right to vote. Everything really, really starts with your vote. Matt, you had your hand up, and then after Matt is Bob.
Yeah, I just wanted to quickly say everyone's spot on as far as the legislative change. Unfortunately, House Bill 96, which is the bill that we worked on last year that allowed for pharmacists to administer post-exposure prophylaxis without a prescription, in the very final hour of the bill being heard on the floor, they snuck in this emergency use vaccine language, which we were opposed to. We expressed our concern around that, but unfortunately it was included in the final bill that passed and was signed into law. I'm glad that we are bringing this up, because I do think it's a place for North Carolina advocates, and particularly our team, to really look into what we can do around this, because when this happened, it was around a COVID vaccine. The FDA approved the vaccine literally the next day after this was signed into law. So it was kind of null and void and didn't really impact that moving forward. However, we did not see MPox being a thing that was going to happen. So it's definitely important for us to look and be more proactive when it comes to this. So it's something our team will definitely look into.
Thank you, Matt, for bringing that up. I also want to mention that it is 1 o'clock. So if you do need to jump, please feel free. But if you're enjoying the conversation, we'll be here for a few more minutes. Bob, you had a question?
Yes, good afternoon, everyone. My name is Bob Finch with Advocacy House, and I'm primarily working in rural counties such as Moore, Montgomery, Richmond. And one of the greatest needs we have is vaccine in these rural areas because there's a lack of transportation and infrastructure beyond the health department, well, without going outside these counties. And I think all the time, like with COVID, we rural areas are like second-class citizens. And I know that's not meant to be that way, but we have people who are living with HIV and all the other issues of society in these rural areas. And accessibility with local trusted partners makes it easier to get these people vaccinated where they won't be spreading it.
Yeah.
So if you guys could get some vaccines out, at least 1 vial per rural county, that would be great. The testing issue also, and we understand the criteria, but don't let us swing out here on this limb by ourselves too long because we don't have as many cases, because in rural areas, we're less likely to utilize health resources in general. Mm-hmm. The data shows that. So make it easier for us.
Thank you, Bob, for bringing that up. That's very important to make sure that that is continued to be echoed. And so thank you for your work and for bringing that up.
I'm going to I'll put my email in the chat before we get off the phone. We do have the ability now to move vaccine or have vaccine delivered to more than 50 places in the state. And then once we get it in the state, we have the ability to move it around pretty quickly. So if you're having trouble accessing vaccine or the local health department in your county doesn't have it or says they can't get it, reach out to me and we should be able to do something about that, because there is now a good bit of vaccine in the state. That wasn't true a few months ago, but now it is true and we can move it. So I'll drop my email in the chat in case folks are having trouble accessing vaccine.
Thank you, Catherine. And I know that I don't want to hold our DHHS team too long, because I know they also have their day to continue with. Dr. Moore, I'm sure, has more things that he needs to do. I want to thank everyone for being on this call and for taking that time out. Thank you, Catherine, for dropping your email into the chat. What we will do next, we have a part 3 that will be coming behind this. But everyone that is on the call will receive a copy of the video. So if you want to share that, we're going to share that to our YouTube page. Is that right, Christina? It will be shared to our YouTube page. So you'll be able to find it there and we'll share that information with you. And if there's any follow-up questions or anything that's needed, please don't hesitate to reach out to us. I will drop my email as well in the chat. But please find us on LinkedIn, Instagram, Facebook, and all of the social media sites. And thank you everyone for being on the call, and have a fantastic remainder of your Monday.
Thank you all.
Thank you.
Bye.
Bye-bye. Got a few left.